Good afternoon to all of you. At the outset, I thank the organizers as well as Team Viva for the opportunity given. Well, this is how the laser console would look like. It's a pretty large console, more than 200 kgs, and the catheter is a very user-friendly catheter. It goes through a 6 French system, and it's a monorail system, and we all know how it works. We have many mechanisms and how it works. Like, you could manage two parameters. You could modify the energy, you could modify the repetition rate. You know that it's a jackhammering effect. You increase the frequency, you tend to hit faster, and when you increase the energy, you tend to hit with much more of energy at the hard lesion. So these are the two parameters that you could modify so that it works harder at your difficult lesions. Now this is how the laser jet would work inside the saline. You could see that the bubbles that's produced inside the saline is much smaller. However, in the second panel, you could see that this is how the laser jet would work inside the contrast. You could see that the cavitation bubbles are much bigger, so that you tend to have a better breakage of the difficult harder tissues. Well, it's actually very useful in situations like this, the uncrossable as well as undilatable lesions. Take you through a few cases. Well, this was a patient who presented with effort angina. He also had an acute coronary syndrome. You could see that there's a calcified right coronary artery lesion. You could see in the lower frame that it's a rugged lesion. It was difficult for us to wire that lesion. So our plan was to go ahead with rotablation. We wanted to get the rota floppy distally. So we tried wiring with a run-through floppy. It wouldn't go through. Then we had to switch over to a fielder XT wire because of that corrugated appearance of the lesion. Fielder XT could go through, but then the caravel catheter wouldn't go distally. So then at that point of time, we tried also with guide extension catheter, the guide plus catheter. With the support from the guide plus catheter, we were not able to get the micro catheter across, the caravel catheter across. So we decided that we go ahead with lacing. So again over the same wire, the fielder XT wire, we tried to get a laser catheter across. That was a 0.9 catheter. You could see that initially it wouldn't go through. Then we tried with the help of guide extension catheter, the guide plus catheter. It could go partially in. Then we tried lacing with the contrast. So with the help of contrast lacing, we were able to get across that particular difficult lesion. Then we were able to, you could see that there is some amount of slow flow after the lacing. Usually we do not come across this sort of slow flow after the lacing. But then finally we were able to get across the caravel catheter, and once the caravel went across, we did rotablation with a 1.25 millimeter, 1.5 millimeter, 1.75 millimeter burr at 180,000 and 200,000 RPM, and finally we were able to dilate it, and that was an angiosculpt used to dilate it, and with the help of guide plus catheter, we were able to get a long stent across, and it was deployed there. And we were at no point of time we were able to get a imaging catheter across that particular lesion. It was so difficult. So the entire procedure was done without an imaging, and finally we were able to get across with a good result. Now this is another patient, a very similar situation, a failed angioplasty, bit anomalous looking RCA and anterior origin of the right coronary artery. A failed angioplasty was referred to us. We again, you could see that the wiring also was difficult in this particular situation. Again, we were able to get across with the fielder XT wire. The microcatheter wouldn't go across, but then this time the laser catheter, 0.9 millimeter laser catheter, high energy, high frequency, it could go in very easily. The second attempt, it went in easily across. Once it was across, we were able to get the microcatheter across the rota floppy and then the rotablation, and then finally we were able to deploy long stent with the help of guide plus catheter, and then that was the final result that we could achieve. These were two situations wherein it was an uncrossable lesions wherein we were able to get across and get good results. There's another doctor who had undergone a bypass surgery, had an acute coronary syndrome. He went to a nearby hospital. They planned for rota. They were not able to get the microcatheter across and was referred to a possible laser evaluation, laser management to cross into the distal vessel. Again, we started off, we wired the lesion with a regular wire, that is a fielder FC wire, and then we did that was the imaging that was done in our hospital. You could see that there is a significant amount of calcification in the distal vessel. We wired with a fielder FC, then started lacing with a 0.9 millimeter catheter. We laced with saline, we laced with contrast, and we also pushed with the help of guide plus catheter. So again, with all these maneuvers, we were not still we are not able to get across. But then this time the fine cross went across, and then it was exchanged for a rota floppy, 1.25 millimeter burr followed by an 1.5 millimeter burr at 200 100,000 RPM. And then again we had to do a lot of things. Imaging revealed huge amount of calcification. There we had to use OPN balloons, we have to use IVL balloons, couple of stents were deployed, and finally with IVL 80 pulses and all, that was the sort of result that we could achieve. TME3 flow, but then still you could see that there is some amount of under expansion in the mid portion of the right coronary artery. Well, this is another case, ostial RCA calcified stenosis, where we wanted to get across that lesion. It was a bit anomalous. We were not able to position the guide properly. In the lower frame, you could see that it was Judkins catheter initially. It was sitting there. Then we switched over to a short Amplatz left catheter. Again, that was difficult to cannulate there. Then finally, we went back to the Judkins catheter. With the help of a guide plus catheter, we tried to push a balloon across. The balloon wouldn't go through. And none of the balloons would go through. Even a 1 millimeter balloon wouldn't go through because the backup support was very bad. But at this point of time, lacing was done with saline as well as contrast. We were able to get across, and then balloon would easily could be navigated, stented, post dilated, and finally we were able to achieve good results. Well, there are situations wherein you have undilatable lesions wherein the lace is going to be useful. This is a patient who had undergone a metal jacket to the right coronary artery long ago. He had a restenosis. Again, he had a second stent implanted in the mid right coronary artery. Both the stents were underexpanded there. So again, he came back with a restenosis there. That was a point where you see that there is significant amount of underexpansion. Exactly at that particular area, you could see that there is again restenosis there. In the first image, you could see that the stent is underexpanded there in the mid portion. So here again, we went ahead with lacing. We went ahead with lacing was done with 0.9 as well as 1.4 millimeter laser catheter. We used contrast as well as saline to do the lacing, and then again that was an OCT run which shows that inside the stent as well as outside the stent there was significant amount of calcification. That was 1.4 millimeter laser catheter. Finally, we ended up having a drug-eluting balloon over there, and that was the final result. OCT wise, the minimal luminal area that we could achieve was more than 5 millimeter square, and these were the images. You could see that prior to lacing, you can see that there's an underexpanded stent, and now you could see that following the procedure, you could see that it's a fully expanded stent, and OCT revealed an area of more than 5 millimeters square. This is a patient who had a stent implanted to the vein graft present with the restenosis in the stent post. You could see that it's an underexpanded stent. Again, we went ahead with the laser catheter, non-compliant balloons, and finally we were able to achieve good results with a drug-eluting balloon in that particular vessel. This is another patient who had a stenting to the vein graft done long ago, almost 10 years ago. Restenosis, heavy calcification, undilatable lesion in the distal portion of the vein graft. It was difficult for us to get across that particular lesion. We used a guide plus catheter, delivered the laser catheter there. The laser catheter wouldn't go through. With the help of saline lacing, we had to use contrast lacing. With the help of contrast lacing, we were able to get across. Here you could see that the contrast amount was low. The ratio was not 25-75, it was 50-50. You could see that there were small bubbles going down the vessel. We'd hardly see it during lacing because these bubbles, the cavitation bubbles, are usually not really dangerous because it explodes and implodes. So you could see that despite that small bubbles being formed there, you could see that the flow is good. There is no slow flow. After lacing, we went ahead with balloon dilatation, angiosculpt was used, and then finally we settled down with a drug-eluting balloon. We were able to achieve a good result in that particular restenotic segment. Well, this was the last case, an elderly gentleman who presented with an anterior MI underwent primary angioplasty to the right coronary artery, and he also had a simple looking lesion in the right coronary artery. We decided that we'll stent that particular vessel also and stop the procedure. So went ahead with a balloon dilatation, 2.5 millimeter balloon dilatation. It opened up. We stented it with a 3.5 millimeter balloon. Once the stent was deployed, you could see that it's not well opened up. You could see that there is a significant amount of under expansion over there. We tried to get in with multiple balloons. None of the balloons would cross that particular area, probably because it was a shelf-like projection over there with calcification there. So we tried multiple balloons. It wouldn't go through. Then we went ahead with the lacing, and it was again a saline lacing followed by a contrast lacing. And once lacing was done, we were able to get the balloon across, and finally we were able to achieve a good flow inside the vessel. This was the pre and post procedure images. I have 2 more minutes left, so I'll go ahead with one more case and stop. This is a patient who had who had a stent implanted to the proximal left-handed descending artery many years ago. Now he presented with effort angina. You could see that there is a very critical stenosis in the proximal left-handed descending artery. He was presented to a nearby hospital. They tried to dilate it. It was not a dilatable lesion and was referred to our hospital with a sheath in the radial artery. So we went ahead with a 6 French guide catheter through the radial approach itself. So our options were probably we could have easily got away with a rotablator in this particular situation because it looked like a calcification. They were not able to dilate it. So however, because it was a 6 French guide catheter radial approach, we thought that we'll try with laser and then if not possible, we'll go ahead with rotablator. So that was a lesion there. You could see in the caudal as well as cranial images. We went ahead with the 0.9 millimeter laser catheter, saline lacing followed by contrast lacing, and you can see the amount of gain that we could achieve, luminal gain. You could see that these are the pre and post lacing images. These are the pre and post lacing images in the cranial view. You could see that we could achieve a significant luminal gain following the lacing. You could see that it was almost 3.2 millimeter with the OCT following the lacing. We made out that there was multiple a huge amount of calcification there. You could see that calcified nodules were there, eruptive nodules were there. So all these things were there. That was the reason why it became underexpandable. Then we went ahead with Wolverine. Wolverine couldn't open up the lesion. That was the Wolverine at 18 atmosphere did not open up the lesion. Followed by IVL, and following IVL, 80 pulses there, we were able to open up the lesion. You could see in OCT there were multiple areas of cracks. You can also see that in the first image it's a calcified nodule and that was deformed and that was fractured with IVL. And then finally we went ahead with stent implantation and that was the final result that we could achieve. Dear friends, the idea of presenting these cases were to highlight the usefulness of laser, the 0.9 millimeter catheter in most of the situations, to highlight the usefulness of laser in undilatable and uncrossable lesions, especially with the case, especially by using contrast lacing in these particular situations. Thank you so much for your patience.